Welcome to Spin Sisters. I'm Mary LaHammer.
And I'm Tara Erickson. And today we are doing an episode about an issue that I worked on for a number of years while I was lobbying at the Capitol, which is around maternal health, substance use disorder, and also in particular issues around toxicology testing, false positives, a bunch of information. So I'm really excited about this topic today. We've brought in some national journalists with us and an expert here in Minnesota. So I'm going to introduce our first guest. Dr. Cresta Jones is a physician who specializes in maternal fetal medicine or high risk pregnancy care, as well as addiction in pregnancy. She serves as the chair of the Minnesota Maternal Mortality Review Committee and sat on the state task force on pregnancy health and substance use disorders. In addition to working in healthcare, she is an educator and researcher focusing on decreasing stigma and increasing access to care for pregnant mothers with substance use disorder. Dr. Jones is also an associate professor at the University of Minnesota, but today is speaking with the Spin Sisters podcast solely on herself and not representing the University of Minnesota. So thank you, Dr. Jones, for being here. And I'm going to let Mary introduce our next guest.
Yeah, we're actually going to have a couple journalists. Shoshanna's going to join us later. But first, Jill Castellano is a data journalist with the Marshall Project, reporting on crime statistics and criminal justice data. She previously worked for ABC Television, the Desert Sun, Salt Lake Tribune. She shared the Pulitzer Prize, big deal, for explanatory reporting in 2018 for her work counting the deaths of undocumented border crosses with the USA Today, and she studies psychology and criminology at the University of Pennsylvania. So I'd love it, Jill, if you could start us off talking about the Marshall Project and this really groundbreaking work in general.
Absolutely. I love working for the Marshall Project. I joined in May of last year. It is a fantastic nonprofit newsroom devoted solely to covering criminal justice issues, and in my view, covering criminal justice issues the right way by really understanding the human impact, getting more than just the salacious true crime stories or the surface level reporting that you see a lot of newsrooms do on criminal justice issues. And because we're a nonprofit, we don't have the daily grind that a newspaper or television might have, a television station. And so we're able to spend a lot of time digging into really important topics that are misunderstood or not known to the general public. And my reporting colleague, Shoshanna Walter, really takes the credit for embarking on this reporting avenue that led to our most recent story that published just around 6 weeks ago. She's been investigating these allegations of substance use during pregnancy and about the women who are accused of using drugs most often as the result of these flawed drug tests. Some of them have false positives as high as 50%, which is a staggering number, and yet we don't have...
Just pause on that
Yeah.
half the tests could be wrong. Like, just to sit on that for a second. Unbelievable.
It's unbelievable.
Yeah.
Yeah, and to think about the implications of that, flip of a coin, and all of a sudden I'm being accused of using heroin during pregnancy, let's say, because I had a poppy seed bagel or a poppy seed muffin. And this really incredible work that Shoshanna has done over the years has built and built. I ended up getting involved to help try to understand and quantify the extent of this problem. Like, how often are we really seeing women get in this trap where they're, accused of using drugs and maybe are facing consequences as a result of that. And that's what led us to our story. And I'm happy to talk about, what we found in that story.
Yeah, what kind of conclusions? How widespread? How big is the problem?
Well, what we were able to find was 70,000 allegations of substance use during pregnancy were referred by child welfare agencies to law enforcement. And so that's a really big number. I mean, also talk about staggering 70,000 cases. And just to back up on that number a little bit, it's data for 21 states, so it doesn't cover the whole U.S. Minnesota is one of the states we have data for, and pretty substantial data. It's 6 years of data in Minnesota. And what exactly this data is showing is like one step in a chain of events that's triggered by the birth of a child. So the mom will go into the hospital for childbirth, and for one reason or another, or because it's mandated, gets drug tested. Usually it's the result of a drug test. It could have a different situation, but usually a drug test. They get tested for drugs, or the newborn gets tested for drugs, and they test positive. We know these are super high false positive rates. They test positive, and then that triggers an automatic referral to child welfare in a lot of places. So child welfare will be contacted by the hospital as a mandatory report and an allegation of child abuse and neglect. And then from there, child welfare could take the additional step of contacting law enforcement to get involved to investigate the case. So what our 70,000 number is actually that last step in the process. So it's just the cases where child welfare has made the decision to contact law enforcement about the case. And then once it's in the hands of law enforcement, they can investigate, they can make an arrest, it can lead to a prosecution, and there can be really negative consequences.
And lose your child. Ultimately, that's the really extreme consequence here, that women could be losing their children over a false positive test.
Yeah,
So,
it's crazy
and
to
Jill,
consider.
I want to hop in. Your reporting on this issue has been fantastic. I watched an entire over 10-minute video package that was a joint venture between CBS Morning News and the Marshall Project. And it was really specifically on the false positives and how bad toxicology tests are. I want to jump into the Minnesota data because in working on this issue for a number of years, I knew that Minnesota was an outlier. It is 1 in 42 births is reported. I think in Massachusetts, it's like 1 in over something 5,000. I mean, it's very little. And that is because of the laws that we actually do have in place. We think of Minnesota as a leader on so many issues, especially in healthcare, and we are not a leader on this issue. What research has shown is the more punitive the laws are regarding these issues, pregnancy, substance use disorder, the worse the outcomes are for moms and babies. So, Dr. Jones, I want to talk a little bit about some of the work that we did when I represented ACOG here in Minnesota and also Hennepin County Medical Center, because our laws were so bizarre. We mandated reporting, even if a woman said, I want help. She still had to be mandated reported, except for, and this is what the oddest part was, alcohol or marijuana. When alcohol is some of the worst substance for the baby or fetus. So let's talk a little bit about how bizarre Minnesota's laws were. We were able to get that changed by bringing bipartisan women together, right? We were able to say that you don't have to mandate report as long as a woman is working a plan of care with their provider. But you were so passionate about this issue, and I used you for so much knowledge and for testifying. So can we jump in a little bit to about Minnesota's laws?
Yeah, thanks, Tara and Mary, for letting me share this with you guys today. I think that it was really, it's always interesting to see what sort of laws welcome you when you relocate. And so I moved to Minnesota and had the opportunity to take care of pregnant women here, high-risk pregnant women in particular, starting in 2017. And what I found is that one of the laws in Minnesota that has been on the books for very long, until 2021, was that if a woman came to me and said, hey, I'm pregnant, I'm really struggling with heroin use or methamphetamine use, and I would like to get treatment, that I was mandated to report her to the county in which she resided at that time because of these concerns of prenatal child abuse and neglect. And what this doesn't factor in is several things. Number one is a patient may not be able to get care right away for treatment of addiction or substance use disorder. They may have to ask off of time from work, get childcare, get transportation. And it also doesn't take into effect a relationship with a provider. So when the first time you meet someone, you say, hey, I'm having a problem with this. And they say, okay, I have to go notify someone else of this provider-patient relationship that we're just starting. It really undermines trust. And so I unfortunately had several cases in following the laws that we are mandated or were mandated to follow that I lost patients very early in our care, both lost them from them coming to me for care and lost them from overdose and inability to keep them safe. And so I was lucky enough to work with Tara and the American College of OBGYNs chapter here in Minnesota to come to them and say, hey, this is what I'm seeing. Has this been a problem for all of you as well? And certainly we found that it was a much bigger problem than just me and my clinic, but it was affecting OBGYNs, midwives, family medicine, pediatrics, and really was behind on what we know about addiction. And I think a lot of these laws were well intentioned when they were passed. But that was when we thought that addiction was a moral failing or a choice that people made where they could just decide not to use substances when they're pregnant. And I only wish it were that easy, right? And so do all of these patients. And so I think the laws were like, hey, if there were a legal punitive action, people are going to change their behavior. And unfortunately, part of the definition of addiction is that you continue to do things even if there are legal ramifications. And so we needed to update our laws to say, hey, this is not patients intentionally harming their pregnancies. They want to get help, but we got to give them time. And we have to not immediately place them under investigation from a criminal legal perspective. It took us a few years, and I cannot thank Tara enough for her wisdom because physicians don't learn how to advocate. I come in and I'm like, here's 25 bits of data and here's 5 manuscripts and this is what we need to change. I learned a lot. And I think there are a lot of healthcare professionals who can learn a lot from Tara and all of you on how you navigate politics, which is very different than medicine. And I think the second law that we have that I'm sure we'll talk about it as well, there are many, I think, but the other one that this is focused on is that if somebody comes in with a complication in their pregnancy around their birth, that seems like it might be related to drug use, you are required to administer a toxicology test. Now, that doesn't have to be right at birth. It can be up to 8 hours later. So maybe somebody got opioids in their delivery and now that's in their drug test, right? And what is a complication of pregnancy that's related to drug use? We can talk about that as well. But I think we've got this sort of vague law that every hospital and every healthcare provider interprets differently. And so that has been an interesting navigation, if you will. And I talk a lot to learners, medical students, and residents. Hey, if you go to another state, really be mindful of what laws might be out there. And if they're bad laws, work towards changing them.
So thank you for that, Dr. Jones. One of the things that I think was really interesting for us is that there really wasn't a set of protocols that were seamless throughout the state. Health systems were doing this all very differently. And what we saw in the data back in the time when we really started working on this bill in 2021 was that obviously, unfortunately, minority women were being tested at much higher frequencies. That went across class, education. It didn't matter. Generally, minority women, mostly Black and Native American women, were tested at higher rates. And not only that, were turned in on higher rates, even for those 2 substances that I talked about, alcohol and marijuana, where they weren't mandated to be turned over for. So it was really interesting. And so the second thing that we wanted to do is say, let's see if we can put a task force together to look at what would be the protocols on why we should be testing. Let's try and have something uniform across the state and look at this issue in a much broader, holistic way because Minnesota is such an outlier.
Yeah, so this was a really great opportunity, and I'm grateful for your work and the legislators who allowed this to be passed because this brought a group of folks together, 20 of us, who wouldn't necessarily have had the time or opportunity to collaborate. And I think the great thing about this is we very intentionally looked at all of the data, pediatric data, obstetric data, addiction data, child welfare data to say, what are we doing in Minnesota and how could we do this better? And really to what you emphasized, the siloing of care is that Child Protective Services, or CPS is what we call it in Minnesota, does this thing. And then maybe it's your social workers in the hospital who report the patient, but maybe it's the doctors and midwives who have evidence to that. And so we really tried to focus on what we were tasked to do. And I think it was really looking specifically at the toxicology testing and then just looking at some of the reporting. And I think that's something that's important to call out is in the state of Minnesota, prenatal substance exposure is classified as child abuse and neglect. And so whether you were trying to get help and couldn't get it, or in the process of getting help, if your infant has evidence of prenatal exposure, you are investigated for child abuse and neglect. And so you have a chronic medical condition, right, that is being identified as, hey, you have this condition, and by definition, that makes you potentially able to neglect or harm your child. And that is...
And Dr. Jones, we are only a handful of states that still has that on the books, correct? Minnesota.
Correct. And again, dates back to that time where we thought, hey, if we have these kinds of laws, we can scare pregnant women or parenting women into doing the right thing, which we know is just simply not the case. And I think so the biggest things that we did is we went through the data and compared it to the laws. And one of the, we had 6 recommendations. One of them was really to address these punitive laws, to change the way we think about toxicology in pregnancy, and to change child abuse and neglect categorizing prenatal substance exposure as a reason for folks to be investigated. Then we also talked about, okay, if we're going to change this, a concern would be, are we going to be placing women or moms and families in places where they don't have resources to, get the care that they need? And so it was looking at what are called family care plans and starting those with someone that the patient trusts. How do we best support the family? And so it's a long report. I applaud you for reading the whole thing, but I think it's got a lot of really cool tools for what we need to change, and also why we need to change them. So it's not just like, hey, I think this is a good idea. It really kind of goes through it. Some of the other things they suggested is something called a notification process, so that you have women who use substances that you say, hey, I'm reporting to the federal, government that we have X many women who had pregnancies that were impacted by substance use or substance disorder. But I had X many women and families where we identified a true risk of abuse and neglect, because those two things are not, they can be not the same. And so I think that's always really important.
We have our other reporter joining us. Shoshanna Walter is the author of Rehab, an American Scandal, and investigative reporter with the Marshall Project as well. And she was a finalist for the 2018 Pulitzer Prize in National Reporting. She's won a Knight Award for Public Service, the Cigna Delta Chi Award for Investigating Reporting, Edward R. Murrow Award, the Livingston Award for Young Journalists. She previously worked at the Center for Investigative Reporting, where her work appeared in the New York Times Magazine. She has been on NPR stations, and she is based in Oakland, California. Shoshanna, let's talk about it, because you were kind of diving into the data. If you can give us some of the context, the data we've been talking to Jill and quantifying. Give us a sense of how big of a problem and what you saw numbers-wise, because this is not easy. We're talking about children. This is private data. Women, we got a sense that there were 70,000 cases that were referred to authorities. But how did you put some meaning to this data and find out when we're talking about children who were taken sometimes from their mothers?
Yeah, not just children who were taken, but also women who were interrogated shortly after giving birth, who were put under investigation, who were arrested, jailed, and prosecuted. There was one woman that I spoke with, Ayanna Harris Rashid in South Carolina, who, like a lot of women, experienced extreme pregnancy nausea, a lot of pain during her pregnancy. Some of the medications that she tried with her doctors just did not work. So she took it upon herself to take CBD gummies, to try a hemp-based ointment to ease the pain during her pregnancy. And then unfortunately, when she gave birth, she and her son tested positive for marijuana. And that resulted in a report to child welfare authorities. And child welfare authorities then forwarded that report to law enforcement. And within a couple months of giving birth, Ayanna was breastfeeding her son in bed. She was sitting next to her husband, just a normal day at home with all of her kids and her family. And she received a call from the police telling her that she was wanted on a felony child abuse and neglect charge, and that she had to turn herself in to the police immediately.
And that might have been specifically related to an ointment or a gummy. You were able to track that or prove that?
Absolutely, yes. I mean, a lot of the tests that hospitals are using are not very specific in what they're picking up. And so the urine drug screen that the hospital used could not really differentiate between a positive result caused by a legal legally purchased over-the-counter CBD product and, an illicit marijuana product or plain marijuana, which is illegal in South Carolina. And there was no way, without further investigation by law enforcement, there was no way a police officer would know that just simply by looking at this report from child welfare and reviewing the drug test results.
Yeah, we should talk about some of the other products too, because there's a poppy seed muffin, poppy seed dressing, there's inhalers, there's bagels. I mean, can you go through some of the things that some of the women would never expect, along with some of the medicines and drugs they were given in
I
their
was just going to
delivery?
say,
Yeah.
I think it's important that people understand that it's not just things that you might be using that are personal care products or food. It is prescription drugs that you are legally prescribed by
Oh,
your physician. We are going to put a graphic up about this. I'd really love Shoshanna or Jill to talk a little bit about some of just also the medication.
absolutely. I mean, the urine drug screens that a lot of hospitals are using, and I know Dr. Jones and I, we've had conversations about this before as well. They're just very imprecise tests. They're almost more like guesses as to what a substance might be present in someone's urine. And so very common foods, medications show up as positives on these tests oftentimes. That includes poppy seed bagels, poppy seed muffins. I've spoken with so many moms who are put under investigation or forcibly separated from their children as a result of eating a Costco salad with poppy seed dressing or a poppy seed pasta salad at a barbecue before giving birth. And a lot of medications that women commonly use during pregnancy, such as labetalol, which is one of the most commonly prescribed blood pressure medications during pregnancy, can also cause false positives for meth, sometimes even fentanyl. And another common one that I heard, this is not a false positive, but it's indicative of some of the problems with these tests, is that women sometimes will receive pain medication during childbirth, sedatives, blood pressure medications, and these can also cause positives on tests if the urine sample is taken after that person has given birth. So women have tested positive and been reported to authorities based on drug tests that triggered due to the fentanyl they received in their epidurals, morphine they received during labor, benzodiazepines they received during labor, even common medications that women receive during C-sections can trigger positive results on these tests and sometimes even transfer to the infant who then tests positive as well. So
Can I ask you guys then about what are people doing about this? Like, I guess what I want to know is, what is the American Hospital Association saying? What's ACOG say nationally? Is there a push? Because I got to believe if there were tests that were 50% potentially false positives that were affecting men and putting them through trauma and taking their children away from them and possibly being prosecuted.
We've seen this for DWI, right? For false positives on
yeah.
DWIs, this would become an issue, right?
We see some major, I think, changes and things would be, I think heads would be rolling at the federal level and probably state levels. What are we hearing from the American Hospital Association, from National ACOG and other groups?
I mean, that's a great question, Tara. I know I've reached out to the American Hospital Association in response to some of our previous reporting and haven't heard much back. I would love to know what these groups are thinking and talking about in regards to this issue. I know that there's been some talk at the federal level about legislation to address some of these issues for quite some time, but there really hasn't been any movement. I mean, as you know, it can be very difficult to get legislation even introduced at the federal level, especially these days. Yeah, I mean, right now we're not seeing too much, but we're also seeing some signs that that institutions are taking this issue a bit more seriously. There are more hospitals that are now looking at their drug testing policies and revising them. And just more recently, we learned that the state of New Jersey now requires hospitals to confirm drug test results before reporting them to authorities.
Okay, so that was what I was going to, because from an earlier report that I read of yours, it stated that no state required confirmation testing or follow-up testing before being sent to either law enforcement or CPS. So we know of one. Basically, New Jersey has done that.
That's right.
That sounds like a bill to me, Dr. Jones. Maybe ACOG's new lobbyists could look at some new legislation potentially next year. I think it's probably because of some of your, reporting and getting so much national attention on some of these issues that there could be could be the potential
But again,
for.
that costs money. I'll jump in, and hospitals are more underfunded than ever. We're in a healthcare funding crisis right now, nationally, locally, at every single level, and
And
all of that
especially with
sounds
Medicaid,
right.
right?
That
And
sounds like it's going to cost money. Jill,
yeah.
we were talking earlier about what a patchwork it is too. Can you put into context how each state has their own policy?
Oh my gosh, definitely. Yeah, Shoshanna and I spent basically a year going to every single state, every child welfare agency in the country, and Washington, D.C. So let's make it 51 jurisdictions to understand what their policies are around when child welfare refers allegations of substance use during pregnancy to law enforcement. I talked about how we only have data for 21 states, but we wanted to know at least the policies across all states because we knew depending on the state you're in, 21 states isn't enough to understand what's going on in your state or your community. So we contacted all these states and we built a map and other visuals that you can explore on our website at the Marshall
We'll
Project.
be putting up these graphics, Jill. So thank you for having those available to folks. Yeah, we'll be putting those graphics.
Absolutely. Yeah. And what the map that we made shows is just how roughly like what the policies are across different states we categorize them into sort of three buckets, and Minnesota is in this one extreme or one end of the buckets, which is states that refer every single allegation of substance use during pregnancy to law enforcement, which means that there's no discretion. It means that child welfare could review the case and say, I've looked at this. I agree that this was the result of a fentanyl in an epidural or a false positive drug test, or that this is not a severe case, but it doesn't matter because they have to refer the case to law enforcement anyway. And then law enforcement makes their own determination, and they could decide to make an arrest, even in a case where child welfare is not very concerned for, the welfare of the child. So we've got that bucket. There's 13 states, including Minnesota, who fall in that category. And then we've got on the other end a number of states that are the opposite, where there's only extreme circumstances that would lead them to refer a case from child welfare to law enforcement. Like there's a meth lab in the home where there's evidence of a really serious crime that goes way beyond the allegation of substance use during pregnancy. I think we mentioned, Massachusetts, less than 1% cases are referred, as opposed to Minnesota, 100% of cases are referred.
I'll jump in. Dr. Jones, one question I have is if a doctor is prescribing something, can't you jump in and say, hey, I gave the mom this during the epidural or this? Do you have some ability to jump in and provide some information that could help the case?
Yeah, I think you certainly can. But as Jill was talking about, the biggest issue is because the law says prenatal substance exposure is potential, the statute says potential child abuse and neglect. There is this fear, which is understandable from pediatric providers, that number one, they don't want to run afoul of the state statute. And number two, they don't want to not investigate cases and potentially put children in harm. And some of that is when you're told this is harmful to children, right? Like if mom had substance exposure, there is for sure a real risk of child abuse and neglect. And I'm not saying that substances don't have impacts, but there are parents who have substance use disorder, who have a community and a village and a support around them that they can parent safely, even if they have returned to non-prescribed use. But there is this fear of, I don't want to place a child in a place where it can't be safe, right? And so it really does fall that based on our statute, based on the way we describe in the state and define prenatal substance exposure, it is better, and Jill and Shoshanna can for sure say what better means, to report everyone and figure it out later. And what that doesn't think about is the trust in the health system and how women who are poor might be seen as having more risk or less support and might be more likely to have their kids taken first and then a full investigation happened afterwards. And what we're sometimes seeing is things that are defined as potential for abuse and neglect in women who use substances, who have less financial resources, less social support, are being disproportionately used to take away children who are Black and Native.
So, Jill and Shoshana, did your data that you kind of uncovered, did you really look at class, race, and could you determine where some of these laws were hitting people the most?
Well, the data itself doesn't specify race or class, income level, things of that nature.
Okay.
Unfortunately, it's something that we're talking about, seeing if we can look into further with the data that we have. And we're making additional requests for additional data. But it's very clear, like you talked about at the top, that these policies greatly impact women of color, people who are lower incomes, 100%. Like the studies have shown, like we've talked about, that these are having a disproportionate impact of women from these backgrounds, and that child welfare are going to examine, perhaps a little bit more closely cases where women are lower income, and maybe they're going to come to the conclusion that they're less fit parents or don't have the resources, or maybe let some of those biases seep in and affect, how they're judging the fitness of that parent to care for that child.
I worked on the opioid bill in Minnesota. When I say that, it was about trying to come up with funding because essentially the cost of opioid abuse was really swallowing local, county, and state budgets, right? Child protective services, the cost of child removal was really swallowing county budgets. It was unbelievable. So we looked at that, and I think it could be because of Minnesota's laws that that's why that was happening, because we constitute any substance use is considered abuse and neglect. Dr. Jones, do you think that was why potentially child protective services and rates of child removals really skyrocketed?
Yeah, it's interesting. And I think that it would be hard. I don't know that we have those data necessarily, but when you look at states such as Connecticut, that's changed to a program where they evaluate someone with prenatal substance exposure and they say, okay, you have exposure, but you've got a good family care plan where we know that you are safer and you have plans in place if you return to use. We're just going to notify the federal government that, hey, we had a birth to someone who had prenatal exposure, but it's not, there's a separate path for abuse and neglect. I have no doubt that that would be less expensive from a county level, right? And I think for your listeners, like every county kind of runs this differently. So that kind of weighs in as well.
But I do want to say that I was really bummed about how the money was separated. Essentially, 50% of the opioid relief dollars that came in with the legislation that we had, 50% went to counties right away to essentially backfill county budgets for the cost of child protective services because they were skyrocketing. And really what probably would have been a more, and the counties needed the money, I understand that, but probably what would have been a better use for those dollars is we have such a lack of treatment available for folks. So if we could have put those resources into treatment services, and specifically we were trying to come up with like family style treatment facilities, almost like a group home setting. It's crazy to think that Texas is doing some really good work in this area, but they are. They've got like essentially group homes where they're doing family treatment. So there might be counseling for the entire family. There'll be drug addiction counseling for the parent. They might have cooking classes. They might have all sorts of different things that are just going to try and get that family back on track. And we lack that. We have very few beds for some of these issues. There's only a couple of facilities in the state for women who are struggling with substance use disorder and happen to be moms or are pregnant. I just wanted to jump in to say that there's not a lot of resources. And I'm wondering if I know that looking through some of your data that you guys uncovered, that out of, I think it was like 9,000 something referrals in Minnesota, that only 1,711 actually needed to be referred to law enforcement or CPS. So when I did the math on that, or when I used a calculator to do the math on that, it's about 75% did not have to be reported to Child Protective Services or law enforcement because there was actually no problem. And so, could we talk a little bit about that? Like, what happens to these people when they're referred? Are they generally charged? Is there just an investigation? Is it different in every state?
Yeah, the data you pointed to is really interesting. It's this breakdown that we were able to get from this data that's collected by the Children's Bureau, that's submitted by child welfare agencies. And the specific breakdown is about how many of these children whose cases were referred to law enforcement were classified by child welfare as victims versus non-victims. So they're going to be classified as victims if child welfare believes that they were a victim of child abuse and neglect. They're going to be non-victims if child welfare decides not to investigate or decides the case is unfounded. Probably these are examples of those would be cases that we've talked about, false positives, women who are given prescription medications, maybe women who admitted to drug use but are on a treatment plan, who are diverted to plans rather than an ongoing child welfare investigation. So you've got this breakdown, victims and non-victims. And what we saw in Minnesota is, upwards of 75 or 80% of the cases that child welfare referred to law enforcement, these were non-victims. These children were non-victims, but the law required that they be referred to law enforcement anyway. So in those cases, it really is up to the law enforcement agency for what to do. We've talked to child welfare agencies and law enforcement agencies who mostly file these cases away and nothing comes of it. But certainly there seems to be police agencies where their goal is to, quote, like err on the side of the baby and basically try to protect the baby by separating the parent and the child, and where they might make a substantial number of arrests. And Shoshanna did some really interesting interviews to that effect that I'm sure she could speak about.
Yeah, why don't you jump in with that, Shauna? Because there still sounds like there's trauma if there's still investigations and separations, and then 75% of the cases turns out it was maybe a false accusation.
Absolutely. What we found is that this is actually what to do with a report once received is a very subjective decision. And it's often coming down to the decision making of a single police officer or a single prosecutor who decides, I want to file criminal charges in this case. I want to criminally investigate. There was one police officer, Jill mentioned, who I spoke with, who acknowledged that many of the drug test results that they're seeing are false positives or are positives triggered by prescribed medications. But he felt literally like they should err on the side of the baby and make the arrest, even if they were uncertain about the accuracy of the drug test results. And there were many police departments that we saw who were making the arrests, deciding to file charges simply based on the report from CPS. They didn't even do any further investigation. They didn't
detaining the mother during that time and taking the mother and child apart, right? During these critical moments between newborn and mother.
That's right.
Just to be clear.
In some cases, child welfare decided to keep mother and baby together. There wasn't any action taken by child welfare to separate the family. And yet law enforcement officers who received these reports still made the decision to go in and arrest the mom, which of course caused a traumatic separation of a mother from her family. And I heard from many women who felt traumatized by that experience, who lost the ability to breastfeed due to the stress and separation from their newborn. So, when I hear, when I hear a lot of explanation from law enforcement agencies, this is for the safety of the child. This is to help the mother get the treatment she needs. Those are some of the explanations that I heard when doing these interviews. I also think about these families that are getting torn apart, that are getting traumatized, who are not served by these policies. Certainly a mother who is no longer able to breastfeed, who's lost that critical bonding time with her child, who now has this enduring trauma that she'll experience for the rest of her life, that is not going to serve that family in the long run.
Yeah, Dr. Jones, could you talk about the value of that bonding time and the trauma and whether a medical opinion could or should be involved during that time?
Yeah, I think the short answer is yes. And there are hospitals in some of these states that have the notification, Connecticut, Massachusetts, that talk about having a huddle. So before that CPS report is made, even if it's mandatory, saying, what are the mom's strengths? What are the family's strengths? What are the harms of separation? And I think I, as a obstetrician, focus a lot on the harms to mom from that separation of bonding. But those colleagues that I work with, we have some great folks here in Minnesota who work in child protection pediatrics. I have the opportunity to work a lot with Dr. DeRalph at Mayo, who focuses on the harms to the child. And so we see generational trauma when a baby misses that bonding time as well. And so when we say we're erring on the side of not harming the child, there may be harms from not allowing them to bond with that family. So allowing peds, who is knowledgeable in this space, and the OB provider to huddle together and say, hey, what information do we need to provide? Because law enforcement has very different training than we do, and we can't expect them to know kind of the health impacts of this. And so I think we have an obligation when we have the opportunity to talk to them about, hey, what do you know about addiction and pregnancy? What do you know about early child separation from their parents and what that might mean for them in the long run? So I think it is really rethinking that, because historically, I agree, it seems like if we can get this infant away from this situation, but really like taking them away can cause impacts that are lifelong as well.
There was law enforcement on the task force that we worked on, correct?
Yeah, we had people from just amazing perspectives that were there. And I think that the problem is, with as decentralized as law enforcement can be with regards to who works with child protection and how decentralized child protection is, it would be nice to see some sort of state or federal, even a consultation line of some sort where we all sort of followed similar guidelines on what is defined as abuse and neglect and what is the next step. I'd like to see those things aligned. So no matter what county you birthed in, no matter what state you birthed in, everyone had the same understanding of what's going to help that family.
I just wanted to speak on something that Cresta spoke about a little bit earlier, which is that we know from studies that have been done over the past decade or so that newborns who are experiencing withdrawal symptoms, one of the best ways to treat those symptoms is to keep mom and baby together, to allow for breastfeeding, to allow for that skin to skin contact. So that's actually very critical for mother and baby to remain together when a baby is experiencing withdrawal symptoms. And as you mentioned earlier, Tara, there's just not a lot of programs throughout the country that allow for that, for mom and baby to stay together. Some states don't have any at all. Other states have months-long wait lists. And we've known that has been a problem for decades. I mean, since the crack cocaine epidemic, there were federal hearings where this was discussed, the lack of treatment availability for pregnant women and for mothers with children. And over the course of the opioid epidemic, the number of such programs has actually dropped substantially. So there are even fewer programs available than there used to be 20 years ago.
Yeah, I think what's been really hard, because I worked on behavioral health issues for many years, there's supposed to be parity, right? Both federal law and state law were supposed to cover behavioral health just like you would cover cancer or diabetes or anything. And it just simply doesn't happen. There's very limited networks, and the reimbursement rates are so low for substance use disorder that a lot of providers are just not able to do it. So I want to talk, just a little bit about solutions. That's what we kind of want to talk about. I think what I heard about confirmation testing in New Jersey going to that, I think sounds like a really good first step on solutions, specifically for a state like Minnesota that is such an outlier in these issues because of how mandated reporting and the abuse and neglect issues. What are other solutions that you guys, through your reporting, or Dr. Jones, that you could give and say this could go a long way to dealing with this issue?
Well, I think Dr. Jones mentioned earlier some hospital policies in Connecticut and Massachusetts where instead of automatically reporting a mother who may have tested positive, they have huddles where they discuss the patient and they make an informed decision about whether or not a report is really required. And that's a policy that I've heard a lot of hospitals around the country discussing. I think the problem is that in many states, when there is a positive screen or there's suspected exposure, state law still requires those results to be reported essentially automatically. So there's not a lot of decision making power that hospitals have once they have these drug test results in hand. And I think that's what New Jersey's new regulations partially address. Instead of just automatically reporting an unconfirmed drug test result, they're now required to confirm that result with a more precise test. And I think some of these other hospital policies that Cresta talked about earlier also give hospitals a little more power, thanks in part to state laws in Massachusetts and Connecticut, to make a more informed decision about whether or not a parent really should be reported to authorities.
Can I ask real quick though? Is it about cost? Are there tests that are much more accurate that can distinguish between a poppy seed muffin and actually opioid abuse or doing heroin? Could somebody consider that?
Right, that are not a fortune that hospitals or policymakers could actually fund.
Absolutely.
Yeah, I think a lot of it has to do with turnaround time. And so you want something that quickly identifies the potential for risk. And then the confirmation tests are more expensive and they do take longer. But I also know that we have a lot of great minds in biomedical research these days. Like, is there a way that we could run this faster and less expensive? And is it perhaps that because it's expensive, you have to sort of what we call batch the labs together? So you have to wait till you have enough of them to sort of run it together. And that may take a few days, because what we see, which goes in line with what Shoshanna and Jill are reporting, is that there's that preliminary, but the confirmatory doesn't come back until the patient's gone from the hospital. And then you often have trouble finding them. And so again, I understand this concern about like, well, we might not be able to find this family afterwards and offer them resources and evaluation. But I do think we need to push to find a way to do it in a cheaper and more efficient way, because it will actually be beneficial from a societal standpoint to have the correct testing done. And pushing people to do those tests only if they're going to change care. And I think that, again, would take a statutory change in Minnesota, but that is what a lot of other states are doing. And it's important to note that when they change this, it doesn't result in increased cases of abuse and neglect that show up later. And so it's not like there is this harm to families that you're seeing by de-escalating some of this screening and testing.
And it also doesn't stop. Like when we went from not having to mandatory report, even if they were asking for help, it doesn't stop a provider who has a license from reporting that patient also. Right. So I think that's an important distinction, is people thought they can't report. No, we're not saying that at all. What we're saying is they don't have to if they don't fear for either the mom or the baby. If they do, they are absolutely allowed and should be with their license to report. So I think there's a big distinction there.
If I can jump in, because Jill talked earlier about 75% of the cases not being nefarious too. So that seems like it's a cost savings too. If law enforcement didn't have to spend all that time and money on 75% of the cases that were not criminal or nefarious, Jill, that would be a cost savings, wouldn't it?
You would think so. And I actually wanted to mention that because, that's another law and policy that child welfare agencies have or have to implement around when to refer to law enforcement, where you could potentially see reforms. Like in Illinois, they used to refer every single allegation to prosecutors because that was required under law. If there was an allegation of substance use during pregnancy, they have to report it to prosecutors. Well, they repealed that. It doesn't work that way anymore. And so that's just another potential link in the chain where there's a fracturing. States handle it in different ways. And so it's not necessarily like it's got to be handled one way or another way. Like it could be malleable.
Yeah. And prosecutors and law enforcement is expensive in government. Just to say
Mhm.
that out loud, that's a lot of time and money.
Absolutely.
Well, ladies, I know that our time is up. Shoshana and Jill, incredible journalism. Honestly, like, thank you for your investigation. Thank you for shedding a light on this issue. Really hope that if you continue and you're working more on this, we could talk to you again at some point. Really appreciate you doing this. Dr. Jones, you're amazing. One of my favorites. I'm just feel really lucky that I've been able to work with you on so many great issues. So you are a blessing to this state, and thank you for doing this.
And Tara, thank you for your bipartisan work on this at the Capitol.
Yes,
So I get to
yes,
thank you
it was
for that.
very
I think,
bipartisan. I do want to have to say, though, it was women.
Yeah.
This issue really impacts women, right? And you had to have buy-in from Democrat and Republican women lawmakers who don't see eye to eye on a lot of different issues. So we had now Congresswoman Kelly Morrison, who is an OBGYN, dear friend of mine. She worked on these issues, carried it for us when she was in the House. And then Republican Senators Julie Rosen and Michelle Benson, who are both, forces of nature as well when they were both there, and they're gone. And so there's really limited choices right now. There's only 3 Republican women in the Senate here. So I think you really need women to come to the table on this, because that's really who it's affecting. And I think that they're more apt to dig into the data and understand these stories, look at the data, but also hear the personal stories from women. And I think that'll affect them more.
thank you,
So
everybody.
thank you. Please like, follow, and subscribe. Thanks, ladies. Bye.
Bye.